Vijay, can you hear me?
Yes, Dr. Raval.
Okay. So we should start. Good evening, everyone. My name is Sumul Raval. I'm a board certified neurologist and neuro-oncologist practicing in New Jersey. I'm a regional director for Mid-Atlantic Region 2 for New Jersey, Pennsylvania for AAPI. On behalf of American Association of Physicians of Indian Origin, AAPI, I welcome you all to this unique and very important webinar on COVID-19 and neurology. I would like to thank President of AAPI, Dr. Suresh Reddy, President-elect Dr. Sudhakar Janalagada, Vice President Dr. Anupama Gotimukana, Treasurer Dr. Raj Bayani, and Chairman BOT Dr. Seema Arora for working very hard on behalf of AAPI. My special thanks to our President Dr. Reddy for working tirelessly and initiating this webinar on neurology and COVID-19. We have exciting speakers for this evening, unique problems. I want to thank them for their time for such a short notice. I will introduce them individually very soon. I also want to thank our panelists, Dr. Gunjan Shukla, cardiologist, and Dr. Ashlesh Dani, neurologist, both practicing in Ground Zero epicenter in New Jersey and New York, including myself. So before we start, we do some housekeeping remarks. Services of RP COVID-19 teleconferences is for information purpose only. It should not be considered as medical or financial advice. RP has no liability as to how this is interpreted, no liability for results, losses, or damages that may cause directly or indirectly or incidentally. Please refer to CDC website and your local state government health authority for information and updates. Each speaker will talk about 7 to 10 minutes. After all speakers will have quick question and answer sections. I want to request everybody who is not speaking, please turn your speakers on to mute if not done already. At this time, I will start with my talk. I will talk about CNS infection and COVID-19 causing neurological complications. Even though COVID-19 has been declared pandemic, our understanding of the disease is still very limited. Given the COVID-19 patient can present with neurological symptoms and signs, neurologists need to be involved, alert, and prepared. We have heard so many experts discussing about so many complications of COVID-19 since it started in December 2019 with the contact history of live animals in Hunan seafood wholesale market of Wuhan city in China, developed an unexplained course of pneumonia. Novel virus was identified and named severe acute respiratory syndrome coronavirus 2, SARS-CoV-2. Later, WHO declared that outbreak constitute a public health emergency of international concern and named the disease COVID-19. As of now, May 6th, more than 180 countries or region with nearly 3.72 million cases with more than 270,000 deaths worldwide. Studies revealed that angiotensin converting enzyme H2 is the main host cell receptor of COVID-19. Since H2 is expressed in neurons and glial cells, COVID-19 may cause neurological symptoms. Considering the neurological manifestation of COVID-19 have been rarely mentioned until recently, familiarizing neurologists with the clinical course of the disease is critical in treating and controlling the disease. COVID-19, as we know, is a novel beta coronavirus in a form of RNA that has nearly 29,000 nucleotides base pair that hold the genetic code for the viral production. COVID-19 is transmitted mainly through the respiratory tract secretions and by direct contact. Asymptomatic persons are also potential source of COVID-19 infection. Based on our current epidemiological investigations, the incubation period range from 1 to 14 days. So talk about neurological symptoms. Neurological symptoms have been observed in patients with COVID-19 from very early stage. The symptoms were grouped into several categories, including cerebrovascular disease-related symptoms, intracranial infection-related symptoms, peripheral nervous system symptoms, and neuromuscular symptoms. And we have speakers for each one of them in a few minutes. Some patients may also present with neuralgia, sensory abnormalities, and sphincter disturbances. Neurologists need to be vigilant about these symptoms outlined, and differential diagnosis should always be considered when you have or hear these symptoms. Intracranial infection-related symptoms such as headache, seizures, or epilepsy, disturbances of consciousness have been described in COVID-19 patients. Given the fact that COVID-19 share common genetic sequences and use the same ACE2 receptor to gain entry inside the cells, neurologists should be considered possibility of central nervous system infection by COVID-19 when facing suspected cases. The first case of COVID-19 with encephalitis was reported in Beijing, China. This patient presented with convulsions and persistent hiccups. Neurological examination at the time revealed slow pupillary response, bilateral ankle clonus, bilateral positive Babinski sign, and meningeal irritation. Patient had a normal CT scan of the head. Recently, a rare case of COVID-19 with tuberculous meningitis is also reported. This further reminds all us neurologists that comprehensive pathogen examination is required when COVID-19 patient presents with encephalitis or meningitis related symptoms. In recent correspondence to New England Journal of Medicine, there were 5 cases of Guillain-Barré syndrome associated with COVID-19 in Italy were reported. The interval between the onset of symptoms of COVID-19.
Sumal,
Yeah.
do you have a slides to show? Or
No.
it's just okay, because everybody's asking about that. Sorry about that.
No problem. No slide. This is most likely the descriptive narration, and then we will have question and answer after that. So as I was talking about New England Journal correspondence, there were 5 cases of Guillain-Barré syndrome associated with COVID-19 in Italy was reported. The interval between the onset of symptoms of COVID-19 and the first symptoms of Guillain-Barré syndrome ranged from 5 to 10 days. The analysis of CSF in first 2 patients had a normal protein level, and all patients had white blood cell count less than 5, which is in normal range. In all the patients, real-time PCR for CSF was reported negative in these patients. The results of electrophysiological study showed axonal variant of Guillain-Barré syndrome in 3 patients and demyelinating process in 2 patients. Further workup, including the MRI with gadolinium, showed enhancement of the caudal nerve roots in 2 patients, enhancement of facial nerve in 1 patient, and no signal changes in a nerve in 2 patients. All of these patients were treated with intravenous immunoglobulins. 2 of them received second course of IVIG, and 1 was started on plasma exchange. After 4 weeks of treatment, 2 patients remain in intensive care unit and was receiving mechanical ventilation. 2 were undergoing physical therapy because of the flaccid paraplegia and minimal upper limb movement, and 1 had been discharged and had able to walk independently. Interval of 5 to 10 days between the onset of viral illness and the first symptoms of Guillain-Barré syndrome is similar to the interval seen in Guillain-Barré syndrome that occurs during or after the other infections. It was not confirmed that severe deficit and axonal involvement are typical features of COVID-19 associated Guillain-Barré syndrome. Guillain-Barré syndrome with COVID-19 should be distinguished from critical illness neuropathy and critical illness myopathy, which tend to appear later in the course of the critical illness than Guillain-Barré syndrome. Saying all these things, recently I also have a very young patient with extensive transverse myelitis in a COVID-19 patient that I'm in the process of writing and presenting in a case report manner, submitting to New England Journal of Medicine, hopefully soon. So at this point, I'm going to stop and invite our next speaker, Dr. Bharat Naravelta. He is the Director of Telemedicine at McLean Healthcare, Michigan. He is attending in stroke, endovascular neurosurgery, and interventional neurology and neurocritical care. He is trained in neurology at Michigan State University. He is trained in dual critical care at UCSF San Francisco. He is trained in endovascular neurosurgery at Wayne State University, Michigan. Dr. Naravetla, please.
Thank you, Sumo. Thank you, everyone, for joining me on this webinar. And I especially thank Abhi for arranging this. So as we all know, it is a lot of data is emerging about neurological problems in COVID in people. So when we look at the numbers, before I start talking about the numbers, what we have looked at is we have something called MISTIC, Michigan Stroke Initiative Collaboration, where 9 hospitals, major hospitals, which contribute the thrombectomy numbers are the part of it. And we always share the information. We collaborate on research matters and everything. And we started looking at the numbers. And a lot of interesting things have come up, during this process. As everybody expected, COVID is causing thromboembolic phenomenon, antiphospholipid antibody syndrome type of a picture and everything. We anticipated in the beginning that the number of cases of stroke are going to significantly increase. But contrary to that expectation, actually the ischemic stroke numbers have significantly gone down. So first I'll talk about the numbers, what we collected, and then we can definitely talk about if there are any questions about the pathophysiology and how these strokes are different from, run-and-mill regular non-COVID. I have a few slides. I don't know how many of you are on the Zoom call where you can see what I'm going to show. So this one. This is obviously the New England Journal of Medicine has published the stroke in COVID patients, large vessel occlusion strokes. They included 5 of them, and those 5, the youngest was 33, and that's how they started reporting it. But let me go to my slides. I don't know, I can't. You guys see Samo?
Yes.
Which one you see? The PowerPoint?
I'm seeing the first curve, ischemic stroke cases, the only first slide.
Yeah, very good. So this is like when you guys see this slide, what we have done is we have compared the March 2019 with February 2020 and the March 2020. So a year ago, and then March a year ago, and then the month previously, and to the month of March. So when you see that the acute ischemic strokes, the number of acute ischemic strokes are around 630, 640 in March 2019, and that is pretty much slightly decreased in February 20. But when you look at the March 2020, there is a significant decline in the number of acute ischemic stroke cases. When compared to that, the mechanical thrombectomy, which we do for the large vessel occlusion strokes during the same period, there is a small uptick in February 20th, 2020, since there is 29 days in the month. But when you look at March 20, there is a significant drop, almost, to the extent of 45% drop in the number of mechanical thrombectomies we have performed in March 2020. And when we look at this, the ICH cases, like a plain old intraparenchymal hemorrhage cases, they also decreased a little bit in February 2020, but there is a small rise in March 2020, but compared to a year ago, there is a significant drop in the numbers as well. Whereas the subarachnoid hemorrhage cases remained, same. Those are the numbers for us. And when we look at this, a lot of things happen. The mechanical thrombectomy drop in mechanical thrombectomy numbers is much more than the drop in the percentage of acute ischemic strokes. The one reason for that, what we noticed is, people started presenting later. They waited on it, probably because they didn't want to go to the hospital, or probably because there is not many people like keeping up on the people who are living alone. So whatever is the reason, these patients were presenting late into the acute ischemic stroke. So by the time they come to us, it was already too late, and infarction had happened, so we didn't intervene on that. There were a few cases, at least in my own practice. I have to do like some subgroup analysis in the entire group. But in my practice, there were 2 cases where I was going to intervene for doing a mechanical thrombectomy, but meanwhile the patients died because of the PE, the other one because of a massive acute MI. So that brings us to the point that, okay, to begin with, probably this case was like, thromboembolic phenomenon secondary to COVID. And one clot went into the brain, and I was trying to act on it. And meanwhile, another clot went into, probably main vessel in the coronary circulation and caused acute MI, or, clot like went into the pulmonary vasculature and caused a massive PI and resulted in the death of these patients. The other interesting thing I noticed is there were 2 COVID patients which we intervened on. I was trying to recanalize. I was pulling the clot out. Clot is coming out, but the vessel is shutting down. It usually happens in the cases where there is a lot of atherosclerotic disease, where you pull the clot, but because of the atherosclerosis, the vessel closes down and the new clot forms, and the problems like that. But the case I'm referring it was a 44-year-old patient pulling the clot, opening up. As long as the stent retriever is there, it is like, nice and clean. Everything is like flowing good. The moment I pulled out, it was shutting down. So in the situations like this, what we end up doing is like doing an acute intracranial stent. So I ended up doing an acute intracranial stent on one of these patients, who was a 42-year-old patient. And, when we do the thrombectomy, we also look at how the clot is looking. Like, is it like a white clot or a red clot? Meaning, is it like from the atrial fibrillation, which is coming up, or atherosclerotic disease, artery to artery embolic phenomenon? And the very interesting thing is, it's not very interesting, but the incidental finding is, it's all like a gooey, like a looking red clot. So that's not a run-of-the-mill atrial fibrillation clot, or like, carotid artery to artery embolic clot. So this all brings down to, so the COVID might have caused or contributed to the strokes in a multi fashion, One, thromboembolic phenomenon, as everybody, was suspecting. That's the first mechanism. And the second mechanism, maybe there is an endothelial inflammation, as New England Journal, Dr. Oxley's article suggested. There may be an inflammation of the endothelium, and all it took is like something, a triggering factor, which would result in a local thrombotic phenomenon, or maybe thrombus formation somewhere else, and then, embolizing to the intracranial vasculature. And because of the inflammation of the vessels, maybe the clot is more sticky to the blood vessels than usually we see. So at any rate, contrary to the expectation, the number of acute ischemic strokes have declined, and number of mechanical thrombectomies have declined even further than the same rate of declination in the acute ischemic stroke. I would stop here and maybe take questions at the end.
Thank you very much, Bharat. That was a very interesting statistic. We were expecting this kind of information, so that's very interesting to learn. Our next speaker is Dr. Anil Yalapragada. He's going to talk about management of strokes in a COVID-19 patient. He is currently serving as a medical director of the Prism Health Richland Comprehensive Stroke Center and assistant professor of vascular neurology at the University of South Carolina. He received his medical degree from the Medical University of South Carolina and completed his neurology residency at University of Chicago and his vascular neurology fellowship at University of California, Los Angeles, UCLA, Ronald Reagan Medical Center. Dr. Yalapragada, please present your information.
Yes, sir. Thank you very much for having me today. Thank you all for attending. I appreciate Api putting this together, and Dr. Reddy, and Dr. Navratla, thank you for sharing that wonderful information as well. I'll just follow up a little bit on that. I'm just going to share a personal story about how this, how our experience in South Carolina and what we were expecting also. We live in a part of the country here in South Carolina known as the buckle of the stroke belt, where the most strokes in the country are happening as part of a strip of land in the southeastern United States, where the mortality index and the young stroke and the burden of cardiovascular disease risk factors and poor outcomes from chronic diseases are at a very, very high level. And specifically in South Carolina, we're known as the buckle of that belt, that buckle of the stroke belt. So we were anticipating a surge. And on the day, a particular week, we had kind of predicted we're gonna start to see more and more of these cases, given the information that was coming out of China and Italy about patients who have underlying burden of diabetes, hypertension, elderly patients, already history of heart disease and stroke, especially, people who have, unstable medical conditions can be destabilized by a viral infection. We see this all the time, even during flu season. And what we saw instead was crickets. We heard crickets. It was completely quiet. Our entire stroke unit was silent, and we were ready for it, but there was nobody coming in, and it became almost like a panic. Like, what's going on? Where are all the patients? Where are the acute stroke codes? We're all waiting for this. And I happen to serve as the chairman of our local, our state DHEC Stroke Advisory Council. So I sent out a mass email to all of our stroke directors around the state, just like Dr. Navratla did, I think, in Michigan, something similar. And everyone was saying the same thing. And in fact, around the country and around a lot of parts of the world, we were seeing this rapid decline. And what we realized was the public health campaign that was put forth for isolation and patients to stay home and stay safe and social distancing and don't go to the hospital if you don't have to, that kind of impetus, actually served to impede a lot of people from even coming to the hospital while they were having a stroke. And this has been shown around the country, not just in Michigan and South Carolina. So when I talk about management of stroke, ischemic stroke during the COVID pandemic or any pandemic in the future, we have to be vigilant in reassuring the public that if someone is suffering from a cardiovascular event or a stroke, that they recognize these symptoms, and they still seek to have that, you know, life and death acute stroke care. That's something that we didn't anticipate. And so we learned that lesson immediately, like many programs around the country. You know, we did a public health campaign to say, look, if you're having these symptoms, you know, you come in. We had all the news stations involved, the media, did Facebook posts, social media posts. And, you know, our entire modern stroke era, we've come so far in our ability to take care of a stroke patient. For thousands of years, we had no idea what a stroke was. You know, we thought whether you're in India, China, Babylonia, Mesopotamia, India, Greece, wherever, there was this stigma about a stroke being something like a curse or a bad omen. Hippocrates actually called it apoplexy, meaning struck down by lightning, something that happens as a punishment. So the name stroke was actually apoplexy for a long time. And that's the same in India, and it's the same in China. It was seen as something foreign, something that was a bad spiritual influence or a punishment. It wasn't until the 1600s when we even understood that a stroke was a neurological disease. And we differentiated it by this guy named Jacob Wepner, who was a famous pathologist, who showed us that there are hemorrhagic strokes, and then there are the bleeding type of strokes and the non-bleeding called ischemic strokes. And so Dr. Neverett showed a beautiful graph about how the changes in the presentation of ischemic strokes and hemorrhagic strokes changed during this beginning of the COVID, and it's somewhat ongoing. And what we realize is people are not coming in when they're having symptoms. They rather wait, so they're out of the acute stroke window, or they're just kind of dealing with them and they're ignoring them. And sometimes the symptoms have improved and they keep going along. But what that doesn't do is it doesn't eliminate the risk for having another event, and without very, very high risk, without secondary prevention methods being put in place. The AHA and the American Heart Association and the American Stroke Association has been kind of learning as we are learning in the trenches, and kind of put out a statement in April very clearly saying that all our metrics, all our protocols, our inclusion criteria for treatment of patients who come in should not change. We should be more vigilant in maintaining our times of treatment and those things, but in a safe environment, so that patients actually feel comfortable coming into the hospital, but also, you know, basically to minimize the risk for patients. So we have minimized the number of people who are around the patient, examining the patient. We're more and more using mobile devices, telestroke, novel monitoring mechanisms, and putting into place transferring patients who have to be transferred into our facility, and then using sister facilities for patients who may have like lower level of care, so we don't burden all our COVID patients in multiple places, kind of saturating them a little bit here in South Carolina. We put a lot of those things from a system standpoint, and we've seen, now we have a steady, we're back to our steady state of stroke patients building confidence back in the community. Without that confidence, people are still suffering. The rates are not supposed to change. And this is, if you look at you know, European Stroke Society or Asian Stroke Societies and Australia, and all the reports are the same. They all went through the same thing. So there has to be a public health campaign to reinforce the decades of education in the community, for whether it's the Be Fast campaign to recognize stroke symptoms and people to call 911, know that, you know, every minute wasted is 2 million brain cells are dying. That kind of information where you act critically and quickly has to be instilled back in the public during a public health crisis. So that's number one for management. Number two, we're seeing conflicting, I wouldn't say conflicting reports, but varied reports on how strokes are actually presenting with this virus. So in the initial stages, again, especially out of Asia, we were seeing a lot of patients who, I think it was like 5 to 6% of these patients with COVID were getting this, developing ischemic strokes. And so we were expecting that we would, and these were elderly patients with underlying cardiovascular disease presenting later in the stage. So we thought this was probably something with destabilization of what we call intracranial athero. Just like we have extracranial athero in the carotids, there's intracranial athero, and in Asia it's very common, especially in China. And so we thought that we'd probably be seeing a lot of that, people being destabilized. And we see that frequently. And I think you said even in the heart, and it destabilizes, and people develop or express their atrial fibrillation or whatnot. But what I would say is that the cases that we've seen here have been like that. They have been the intracranial athero that's been destabilized, as opposed to the reports coming out of New York and some other places where they're showing that there's a, this in situ hypercoagulable demonstration, almost like a DIC picture. But what I would say to you is that doesn't mean that that's, it could mean a number of things. It can mean, one, maybe there are viral subtypes out there that are affecting the cardiovascular system and the vascular system in different fashions. And we're seeing different presentations in different age groups. For example, in New York, it was a younger group versus in China, maybe it was an older group. Doesn't mean that, it just means that there's racial differences, there's ethnic differences, there may be some viral differences, subtypes, and the virus may act in different fashion also. So we were just talking about the ACE2 receptor. The spikes that you see on the COVID are actually specific to binding ACE2. And so that's why we get almost this pulmonary intravascular coagulation cascade, just like you have a disseminated intravascular coagulation cascade. That's why you have the bloody lung parenchyma. You can have thrombi forming inside the lungs. But that ACE2 is also presented within the brain. And so what happens is when the virus binds that particular receptor on the blood vessel, it exposes the endothelium. And underneath that endothelium is von Willebrand factor, and then you have free factor VIII flowing. You have acute phase reactants, so you're in a hypercoagulable state somewhat. Now you have injury to the endothelial wall, and plus most of these patients are sick or they're getting sick because this happens after an incubation period, so they're static. So that means you have Virchow's triad, right? Stasis, hypercoagulability, and injury to the endothelium. You have a perfect milieu for massive thrombosis, which is why we frequently see patients like you were, Dr. Neverett was describing, with a stroke, an MI, a DVT, because it's not that there's one source of embolus that's going multiple places. It could also be that it's the vasculature that's being attacked. That is the theory. That's why the kidneys are also injured, they think, as part of the acute renal injury, is because of the vasculature that's within the kidneys, where is potent with ACE2. So someone is just, I'm only able to capture a few questions, but there are a lot of questions popping up. There's actually about a few papers just came out, I think today, and someone asked just now about ACE2 inhibitors. Why don't ACE2 inhibitors work? There's a lot of work going on now, not randomized trials, but observational trials, specifically about ACE2 inhibitors and and ARBs, and seeing how would they be effective or would they be harmful in this particular scenario. And it's been somewhat of a paradoxical effect. I think the paper was in the JAMA Cardiology today, and then there was one on May 1st. I think that was a New England Journal. But the point being is that ACE2 is not only responsible, so the damage done to the endothelium is not the only source that increasing the von Willebrand in the blood vessel. The ACE2 receptor actually has a potent effect on oxidative stress in causing further damage along that whole area. So there's an inflammation in addition to hypercoagulability that's occurring. That inflammation is now also, we see that systemically. And so a lot of the therapeutic modalities for treating this disease we're seeing are starting, methylprednisolone early, getting anticoagulation on board, especially in patients who are presenting with D-dimer early. D-dimers typically reflect this kind of damage to the endothelium, which shows that there's multiple thrombi maybe forming and healing. And so if you measure a patient at day 5, day 10, day 20, day 24, you'll see or day 20, you'll see the spike in certain patients who are more prone to forming these clots. And this is out of Sweden. They were looking at dialysis catheters, specifically people clotting their dialysis catheters, I believe, and they started noticing this tendency for hypercoagulability and elevated D-dimers. And so one of the things is if you have patients, especially if they have cardiovascular disease risk factors early, and they're presenting with COVID infection, and you start to see them deteriorate, and you start to see them developing these elevated D-dimers and reactive proteins, and they have a history of stroke or heart disease, it may be prudent, it may be proactive. Just start your anticoagulation. I think that's what a lot of the trends are happening in New York and around the world, is people are getting early anticoagulation started to prevent these ischemic strokes, heparin drips, and fully anticoagulating these patients earlier, before they, as a preventative mechanism from developing these, DVTs or pulmonary thrombosis or even ischemic strokes. The other thing is like Dr. Neverett was saying, and also that was presented in the New York articles in New England Journal, was the concept about this, doing a thrombectomy, then the clots are forming after, and then they rethrombose. So once a patient's presenting with these clots, they need to be fully anticoagulated. Typically, when we do an ischemic stroke protocol, you know, whether a patient gets IV thrombolytic and TPA, we kind of sit back and we monitor them, and we're worried that if there's a reperfusion hemorrhage or hemorrhagic conversion. So we typically are cautious with anticoagulation unless maybe there's a subocclusive thrombus and you're worried about rethrombosis. But in these particular patients, COVID-19 patients who you're doing thrombectomies on, it's better. I've worked with my neurointensivist, and we will start anticoagulants on these patients prophylactically for some time as we let the endothelium heal and not precipitate more clots. But it's a very interesting pathophysiology, and it's not that common, actually. We haven't seen that here, the hypercoagulable intracranially, of course. And part of the reason is maybe patients are just dying sooner. They're not getting to the point where they're actually having the presentation as an ischemic stroke. Remember, there's different ethnicities present different patterns, there's regional differences, cultural differences, age differences. I don't think, and there's a lot of questions on what should we do here, what should we do in this situation, or we haven't gotten to the point where we can standardize, which is the third thing in management that's happening. We can't say this is a standard protocol for every COVID patient, whether you're in New York or South Carolina or China. But what I would say is that we're forming, the AHA and the ASA has formed a registry, and that registry is collecting all these patients who present with stroke with COVID. And it's going to take months to maybe even a year before we can really break down and analyze, you know. And until then, we're kind of just trying to read up on best practices and successful stories, just like it is in the general infectious disease management, where we're trying to understand what's the best, you know, how we're going to form the vaccine or the medicine. So there's a lot of questions popping up. So I guess we'll just do that in a question session, because I just got a text saying I should stop talking. So. Thank you.
Thank you so much, Anil. This was very, very informative session, and I'm sure you provided so much useful management things for the neurologists. So it is very, very useful. Thank you so much.
Thanks.
Our next speaker is Dr. Nikesh Ardeshna. He's a medical director of epilepsy services in Malvern, Macomb, Michigan. He's going to talk about seizures in COVID-19 patient. Dr. Ardeshna,
thank you.
are you?
Yes, I am right here. Can everybody hear me?
Yes.
Okay. Thank you. Thank you, everyone, for having me this evening. I appreciate everyone joining this evening. And again, thank you for the opportunity. I want to also echo the comments by our speakers that all of this information that we are presenting is truly cutting edge, and there's much more of it to come. So what I'm going to focus on to keep everybody on time is just some of the stuff that we are seeing with respect to seizures and epilepsy with the COVID-19 pandemic. Somewhat similar to what the other speaker said, when this started about mid-March for us in Michigan, and I work at the same place as Dr. Nerventla does, so he's my partner there as well. A lot of epilepsy business dropped off, and the bosses were very unhappy, but it's just the case of what happened. Patients didn't want to come in, they didn't want testing done, and there's entirely a possibility when I've talked with other epilepsy centers that there are probably some cases of new onset seizures that have been missed or that we are seeing now. What we do see now as of May the 6th is starting roughly for Michigan, the first or the second week in April. All of a sudden, we started seeing a lot of encephalopathy cases, and many of these were COVID encephalopathy. So what I can tell you is from the cases that our team has seen here, the first two cases, which were non-intubated patients, they were COVID positive. One was in their 50s, one was in their 60s. Fairly typical history. The EEGs that were done, these were routine EEGs, so my practice focus is basically on the reading of either routine or critical care EEGs. both EEGs came back almost exactly the same. In fact, when I read the EEGs, I thought I was reading the same patient, and I had to make sure I was reading the right patient. And that's kind of what led our team to start keeping track of this more and start saying, okay, is this true? And we asked around some of the other epilepsy centers here in Southeast Michigan, and the pattern that we saw on these two EEGs is, from an epilepsy perspective, it is an encephalopathy pattern, sort of a moderate encephalopathy, not necessarily a severe, but a moderate. And it actually had frontally predominant slowing in the brain, along with triphasic waves. Triphasic waves we often see in the setting of metabolic issues, be it kidney, be it liver, medications can do it, low oxygen, low sugar. But those two, at least from what we have heard anecdotally and also comparing to the East Coast and West Coast, those two findings, frontal slowing with triphasics, are the most common findings right now that we're seeing on routine and continuous EEG. Then as time progressed we're going into April now, we started seeing as the COVID patients as they increased in number and also severity, a lot of these patients were intubated, some still are, and they spent much more time in the ICU. So we ended up with, just by virtue of encephalopathy cases, putting these on continuous or critical care EEG monitoring. And what we saw was, first of all, same thing, the same pattern, a moderate encephalopathy. But also then, as the cases continued, we saw a difference in terms of severity. There were some people that had a mild encephalopathy, moderate, and then also very severe, to the point of almost what looks to be an anoxic arrest, like 1 to 2 hertz diffuse frequency slowing. So then the question that's still out there and that where everyone's kind of looking into is, can COVID-19, number one, can it cause new onset seizures? I can tell you personally, I have not seen a case of it. Anecdotally, I've heard some of my colleagues say, and some of our other neurologists, that they have seen it. So I can't comment further on that one. It's not that common that we are as yet, but again, we're early into this because a lot of the neurological things, as was mentioned at the outset of all of our talks, have come in somewhat later. But what we are seeing now, and this again was April into May now, is encephalopathy, encephalitis, and meningitis. There's been a couple of people who have who've presented with just the waxing and waning of mental status over days. In fact, we had a 44-year-old who really came in, was tested once negative, discharged, was encephalopathic, came back, and almost had psychotic features. Although that may have been med-related, but she was clearly encephalopathic from other issues. Her condition continued to deteriorate, and she actually ended up in status epilepticus. And her third test was COVID positive. And this was over the span of roughly a week, first admission and then 10 days later. From the standpoint of other areas that epileptologists are looking into, we've talked this evening about the mechanism, how COVID causes the neurological conditions. So there is a thought, although unproven, to see if certain anti-seizure medications, certain anti-epileptic drugs actually are better suited for it than, say 1A versus B. We don't have that, but people are looking into that right now. From its mechanism of how it causes seizures in the ICU setting, we're still thinking cortical irritability. Do we have a particular location? Not necessarily, but still the cortical irritability and hyperexcitability. I will, as we close out on my part, I'll also mention one thing, which was very common to what we were just talking about with strokes. A lot of the outpatient testing and stuff that we do for epilepsy declined in volume, and rightly, because patients were saying, I don't want to come in if I don't have to come in right now to the hospital. I'll postpone everything. There have been also cases reported of patients who have epilepsy and they have been tested positive for COVID-19 and they've had breakthrough seizures. We think the breakthrough seizure is because of the infection, because as you know, any infection can reduce threshold, but we haven't been able to pinpoint more than that. Now, I will tell you, and this will close on slightly a lighter note, as we are all still living through this and working through this, I actually, myself, as well as a lot of the other epilepsy directors, closed down their epilepsy monitoring units because these were all elective admissions. I actually had one patient that I had seen roughly March the 10th actually ask me 3 times if she could come into the epilepsy monitoring unit and spend a week with me in the hospital so I can diagnose her, even in the middle of the pandemic. And I unfortunately had to say no for safety reasons. And I'll be happy to take questions. Thank you.
Thank you, Nikes. That was very useful information. We're very, it is very good to learn that in spite of a lot of thromboembolism and a lot of fear of people having increased incidence of strokes, it is not the case. So that is definitely good in a way. For seizures, similarly, its incidents are not higher, or maybe not many people are seeking medical advice, so it is unclear. But it is very clear that CNS infection definitely has a lot higher incident, because we have about 30 to 40% of our census out of 30 patients in a hospital have encephalopathy. And since not everybody is doing routine spinal tap or CSF analysis, it is almost impossible to put the exact numbers on those things. But this will conclude all the speakers at this time. Now I will ask our panelists to go ahead and start the question and answers with speakers.
Thank you very much, Sumul, for inviting us for this meeting. I'm Gunjan Shukla, one of the cardiologists and electrophysiologists at Hackensack Medical Center in New Jersey. And such a fantastic presentation looking at a neurology narrative of COVID-19. In many of this respect, the heart and lung is similar, and both can be affected by vascular catastrophe. And we are beginning to understand that this is a vascular problem which happens a lot with the COVID-19. Excellent presentation by Dr. Yanapagara about the vascular pathogenesis of endothelial dysfunction, and by Bharat also. So one of the question came up with that the mechanism may be either direct viral attack on the endothelium versus inflammatory storm attacking the endothelial, causing endothelial dysfunction and causing a local clot. Is there any role of anticoagulation, or is there any role furthermore that can we start anticoagulation outpatient to prevent catastrophe? So either of you, Bharat or Anil, that would be great.
Bharat, you want to go ahead?
I wanted to ask the same thing.
Okay.
So, I can touch upon a little bit as a inpatient side, and then you can
Sure.
continue that for the outpatient setting.
Sure.
So I've been seeing the questions on the chat box, like, what about the anticoagulation immediately after the stroke and stuff like that. But the thing is, the Gaurav was saying in the chat box that, there is an increased trend towards the hemorrhagic conversion after the thrombectomy. I agree with that. I have seen 2 cases where there is a hemorrhagic conversion, which I would not expect. See, after the stroke, when we pull the clot, we usually know whether it is going to have any hemorrhagic conversion or not. And there were 2 cases absolutely threw me out of the box completely, and there was hemorrhagic conversion of that ischemic stroke. So I think there is a trend. I don't know, I can't disprove it at this point, but I think there is an increased trend towards a hemorrhagic conversion after the ischemic stroke, after you do the thrombectomy. So for that one reason, I think we should be a little bit extra cautious in starting the anticoagulation. And having said that, the people who were already already on anticoagulation, and when they came in with ischemic stroke symptoms or any of this, did they appear to fare better than the people who were not? I think I want to say yes. And that is also proven, as we all know, that anticoagulation is giving some protection towards the thromboembolic phenomenon in the COVID patients in general. So maybe anticoagulation has a role if there is not a major stroke to begin with. And if there is a major stroke, I would reevaluate after what happens, and then go from there. And Anil, you can talk about the outpatient setting.
Sure, I agree, and I think using our modern multimodal imaging technology that I'm sure you guys are definitely using, and if we're able to show that these patients may be early in the time window when they're getting their thrombectomy, or they have a small core on perfusion imaging with a large penumbra, those type of patients who may be good candidates for recanalization, maybe those may be optimal patients, because I believe a lot of these cases that are being presented specifically out of New York, not just our run-of-the-mill thromboembolic or unstable atherosclerotic plaque. I think that a lot of these patients are actually local thrombosis that's happening, and that's what we're seeing in the lungs too, and that's what we're seeing in other places. So it almost seems like if there isn't a vascular bed, a vascular ischemic bed that's susceptible to hemorrhagic conversion, I think we need to protect the vessels themselves, because the patient has basically showed their cards that the virus is now in a state where the endothelium and the systemic milieu is very unstable. So I guess I would tend on the side, and I think after discussing with my neurocritical care staff here and my attendings, we're all kind of like on the same page that if we do get that scenario, we'll consider. We haven't had a lot of, to be quite frank, we haven't had tremendous experience with COVID patients here that are presenting with stroke, because again, most of them are multi-organ failure patients who are so sick, and we don't see that. We haven't seen the presentation of them purely presenting a stroke like you guys have in Michigan or maybe some other places. As far as outpatient setting goes, I think it would be, certainly if the patient has a reason and indication to be on anticoagulation, it would be a good idea to get them on. But and I get a lot of my friends asking me, hey, should I just go on an aspirin daily just because, maybe that'll help me without, if I do get COVID or, for not having a stroke. Because that's what happened when this newspaper article came down in the Washington Post. There was a huge panic. Young people getting strokes is what the article was, And so I think that it would be a little premature. But if there's, I think, patients who already, have cardiovascular risk factors and whatnot, and then present with COVID, I think it's not unreasonable, just to make sure they're on their current antiplatelets and whatnot.
Great, thank you very much, and that's very informative. The other question came down in the area from Dr. Janalgada that frequently one of the symptoms for the COVID-19 is headache, and whether headache is an isolated phenomena because of COVID-19, or it could be an indication for future involvement of neuro or brain or stuff like that. Can you elaborate on that?
I think I can take that question. I think headache is a very common symptom when people have any kind of, when we have common cold-like symptoms, we get a headache as well. So headache is very, very common neurological symptom when you have milder kind of basilar, viral, milder meningitis situation. So if even a simple, without the COVID, even a simple severe common cold with headache, if you do the spinal tap, I bet you will find some WBCs and a protein into those CSF. So in a situation, in a COVID, where informations are so much limited right now with the CSF sampling, I think you should consider that early symptoms of involving CNS, or CNS infection. So we watch that person also carefully as people with pulmonary involvement with pulse ox, going down.
Great. Another question comes from Dr. Dandamudi, is Now, COVID has a variety of presentations. Sometimes it predominantly affects lungs, sometimes predominantly affects heart, renal, neurological involvement. So the question is this variety of presentations are related to different mutation of the virus? Is any panelist want to take on that one?
So I think that's very interesting questions. So much mutations have been talked about this virus. It is unclear because there are so many people having asymptomatic or minor diseases versus somebody with having severe disease, with certain countries having more severe mortality. Even by United States, certain states have less number of severity or mortality than other states. So I think there is a good possibility of having genetic mutation, and I think that is also playing important role in developing the vaccine as well. So I think it is the information is not 100% clear, but it is important information.
There's actually an interesting phenomena that was actually written up. I think it was today actually, and it's basically looking not maybe it's not just, or maybe it's not related to the virus itself, but genetic and racial variations. And this came out of Ireland, in an Ireland hospital, and they were looking at exactly what you're saying. You know, there's different expressions of ACE2. There's different expressions of and propensity in different ethnic groups that they looked at and how they were presenting. So it may be, obviously, it needs to be a much larger. And once we have a global perspective, when we get these registries formed, we may be able to see that, hey, look, you know, this subpopulation was more susceptible. You know, Africans may be more susceptible to the renal injuries versus the, you know, the Irish who are more pulmonary versus, you know, these individuals were almost, you know, we will start to see those patterns as we move forward. So it may not just be viral subtypes. It may actually be racial variations, cultural, genetic, a number of different factors we need to look back and see.
It's very, very important because there are so many factors involved. We have a lot of information coming out. So I think it's very important to know. My one question to both stroke neurologists from my end, with the micro endothelial versus large vessel occlusion, what do you think if the damage is occurring to the endothelium level? Do you think you're getting large vessel disease from the vascular standpoint, or just a smaller stroke with capillary thromboembolism?
I can take that
Sure.
first. See, I think it is not very well understood phenomenon. You know, these are all like theories we are talking about, ACE receptors and the endothelial activation and the inflammation and the cytokine storm and all these things. How you plug in everything together, we do not know. For example, that patient which I did, that 44-year-old, where, you know, the clot is appearing like, you know, and the guy doesn't have any intracranial atherosclerotic disease, and he does not have any other problems. And the clot appears as if it is very gooey and stick to the endothelium. So it is hard for me to convince myself or convince anybody to say that it was an endothelial inflammation, local endothelial damage or inflammation, which has, you know, which is the inciting reason for that, for the clot to form. And, you know, the other thing is, the other possibility I can say is like clot might have come from the heart or the carotid, and then not from the carotid because his carotids were clean, you know, came from heart and went and stuck to the blood vessel. And already there is an inflammation in the body and endothelium is activated. And now I pull the clot out and I might have raked up the system, which is actually prothrombotic at that stage. So it's very hard to say what exactly is the inciting and causing the ongoing processing there. And coming to the small strokes versus the large vessel occlusion strokes, see, if we expect that the microthrombi forming and then like going everywhere, microthrombi is unlikely to go into just one vessel and cause a stroke in one particular vessel territory. You know, if they form, they go everywhere, and there should be more than one ischemic stroke, even though they are small. So that brings us to another point where, like our subarachnoid hemorrhage patients, once we secure the aneurysm and put them in the ICU, and while we were monitoring, surprisingly, there is an increased trend in that subpopulation, that they started having multiple small ischemic infarcts. And now the question is it because of the vasospasm which has resulted because of the subarachnoid hemorrhage, or vasospasm has contributed to the already, people having a propensity to form the clot, thromboembolic phenomenon? It's very hard to say at this point, and I think we need to study this much more than what we have already done.
That's, I think,
excellent presentation. Thank you for providing such a wonderful information, first-hand information, because this is a really and a very unusual disease with unusual presentations, and we all were not ready for it. Two questions. One for Sumul. For the diagnosis of encephalitis, does it require any specific way? And if that's so, is there any specific treatment that's been tried that is somewhat more effective in its outcome?
Right. So I think the diagnosis is conventional way that we do the spinal tap analysis, look for the cells and a protein and other pathogens, and that will help us decide whether there's any other etiology for encephalitis or meningitis or meningoencephalitis. The bad thing about this, there's no known treatment that we know that works for CNS infection at present time. So even though we think that person has meningitis or encephalitis or meningoencephalitis, to avoid the exposure to the either procedure performing neurologist or other physicians or interventional radiologists, we just treat them conservatively with whatever antibiotics that we think, including the common bacterial antibiotics.
Great. And a second question for Nikesh. Is this seizures are being treated with the same conventional anti-seizure medication, or any specific medication works more better than the others?
So with respect to, that is a question that's still being looked into, if one anti-seizure medication is better than others. It is conventional, with the exception of if we have a status patient, then we're going into the status protocol using IV sedation. I'll just piggyback onto what Sumal said, that we did it with, if we have seizures, we had one case with seizures from encephalitis. In that case, again, we used IVIG first after trying everything. And then there was a thought to use Rituxan, but no, we didn't go there. So IVIG we did use on one case.
And what was the outcome for that?
Unfortunately, not good. We knew it was all, this lady had probably been seizing already a couple of days before she came in. So it didn't really help the situation much.
Thank you so much. And one another question, as outpatient perspective, when these patients are coming out and are they still assuming more risk as a stroke thromboembolic phenomenon? Is there anything looked at it like outpatients anticoagulation, starting them early, those who are not as bad outside but started developing symptoms afterwards?
I guess I'll answer that question. I don't think, just the common theme is we don't really know yet. This is so new to everyone. But I think that the course of the increased rise in reports of thromboembolic phenomena, specifically intracranially, are in patients who we've seen that there's been these in the acute phase situation with the reactants and the D-dimers and during that 20-day period where we're seeing a lot of this stuff go sour. But by the time these patients are ready to go to outpatient, I think they've stabilized. So you just kind of modify their risk factors and you maintain them on whatever secondary prevention you normally would. I don't think you may need to actually put them on a NOAC long term or something like that. That's my understanding. You're kind of treating this as an acute viral illness symptomatology, and then once they stabilize and they're doing well, but again, it would be a case-by-case basis, and I think we're still learning.
Very good. There's one of other question popped up for Bharat. I was really fascinated by your presentation. One of the guy, you pulled out the clot and vessel kept collapsing, and then you had to put a stent in. Now, being a cardiologist, we are also interested in the vasculature as much as you are, and the question is that we obviously see a different kind of clotting in the heart vessels compared to the brain vessels. Our main experience is a clot busting, and the immediate thrombosis, and the stent really helps in that situation. Where the neurological vasculature, that's not the case usually. So, did you suspect that clot might have busted in that area, or it was just a vascular endothelial dysfunction? And if it is, what was the length of the stent you chose, and why?
So that's a good question. So when we deploy the stent retriever for the clot integration, you can actually see what's underneath. If the vessel is like, what is the size of the vessel and how far the clot is extending and all that. So we call it a reperfusion channel. So as long as the stent retriever is there trying to like engage the clot, you get that idea. And once you pull the clot out, the expectation is, okay, the clot was there, I pulled it, and it should be open now. Now it was shut down. So the clot has formed new. It's a thrombotic phenomenon right there. If it is a atherosclerotic disease which is pressing on it, and then like as long as the stent retriever is in there, it is like keeping the perfusion channel open, and you pull it out, and it is collapsed. This is the information. It's a dynamic information. You get it during the procedure. So in this case, as long as I wish I could show all those pictures. In this case, there was this clot right there, which is like about like 5 to 6 or 7 millimeters in length. That is where the stenosis or occlusion was there. The distal M2 branches are like open, and the proximal M1 middle cerebral artery branch was open. And it is a focal stenosis versus focal thrombotic phenomenon. And it was closing down, and it was like 5 to 7 millimeters, not more than that, maybe maximum like 10. So I chose like 21 millimeter stent in that case, and I nicely extended into the one of the branches of the middle cerebral artery, and that kept even the other branch open. So that's usually is the case which we see with atherosclerotic disease cases. Yeah. But there was no atherosclerotic disease. He was a 44-year-old, and no atherosclerotic disease anywhere else.
Yeah, it was fascinating.
I think this atherosclerotic phenomena is just so unexpected and unexplained that there is possibilities of so much unknown at present time that does not help to manage these people properly. I have Hema. Vijaya, can you unmute Hema? He has a question for somebody. Hema, are you there? Maybe we dropped him.
Trying to unmute. I want to thank Karthik and Gaurav and Vivek on the other side, and Brahma in the chat box. They're answering a lot of questions.
That's great. I have one more question while we are waiting for another person to join. For Dr. Naraveltla and Dr. Yalapagara, that Dr. Samavadi is asking if patient had a clots, were they bleeding at IV sites? So I think they are trying to ask whether they have a simultaneous sort of DIC kind of features.
Can you ask the question again?
So they are asking that the patient you experienced who presented with shots, either stroke or acute thrombosis, are they also bleeding from the IV site? So where their IV were, they were bleeding there or not? So they were asking that they're simultaneously they are hypercoagulable or not.
I haven't seen. I think we take the question first and Anil can follow. I did not see that in COVID patients, but did I come across people bleeding from the groin side? Yeah, definitely. There were times where, closure device failed and the people have bled into the thigh, and that complication do happen, from time to time. It's not uncommon complication.
Yeah, I think the question was more towards whether they did have some sort of DIC where you see thrombosis at some point and the bleeding at other area.
I haven't seen. Fortunately, I didn't come across that thing where the patient having a DIC and having a thrombotic phenomenon. But in my life, I may see one. It all depends on which one is prevailing, And on the same note, I want to tackle one question from the chat box. Someone was asking if there is a PE, massive PE, and then acute ischemic stroke. The question is very simple, whichever is going to kill the first, we need to tackle it. And if the PE is massive, there is no point me taking the patient into the lab and trying to open up the clot. I would give the clot busting medication there, or do a pulmonary thrombectomy, and then take the patient to the suite and do the cerebral thrombectomy. If the PE is small, it is not too big, and then if the clot is bigger and it's a debilitating stroke, then I would take the patient to the mechanical thrombectomy of the cerebral clot first, and then send the patient for the thrombectomy of the pulmonary clot. And there was a question about do you use anticoagulation in that situation? It all depends. If it was a clean flow and I expect no hemorrhagic conversion and the follow-up CT scan shows a minimal stroke, then I don't mind starting the anticoagulation on those patients rather soon.
One more question has come up in the chat box is, do we, with whatever data, what we have it right now, do we recommend as a primary prevention any antiplatelet or anticoagulation?
Yeah, I think I answered that a little while ago. If a patient is symptomatic or positive for the test and they have underlying cardiovascular disease risk factors, then yeah, I think if they're not already on something for primary prevention, they should be on something. It's totally reasonable, but I wouldn't just recommend a mass, initiation of blood thinners and antiplatelets in our population.
Anil, this is Lokesh. One of our outpatient doctor, his D dimer is 1.2. And do you consider one of the thrombolytic? Can you hear me?
Number of different reasons, right? Can you hear me? Sorry.
Yeah, go ahead.
I'm sorry, my video turned off too. I was going to say sometimes the trend is important, and also if they're symptomatic and what kind of risk factors, those things all matter when you make that kind of decision.
He's a 60-year-old healthy and outpatient, and on steroid. He was a fever 14 days, and we started 14 days fever, COVID positive, and steroids were given 80 milligrams a day for 5 days, and now the D dimer is 1.2. And what do we consider? Or
is it downtrending, or is it where was it before?
I'm not sure what was the level. I think we're going to get another level and see.
Yeah, depending on that, and if it continues to rise, then I would definitely put him on something, just prophylactically.
If it was 0.5 and went up to 1.0, then you would have added.
Yeah, I think that's not unreasonable. I mean,
Okay.
again, we don't know the right answers, but from I forget if, I think it was out of New York also, but they were looking at they were looking at the chronology of looking at the patients who developed thrombosis, looking back at how their fibrinogen levels were increasing. And it was just kind of like a doubling. And then all of a sudden, it went up very high, like 20s.
Okay.
So I think that, the trend is very important here.
Thank you. Next.
I think we have so many questions that we have received so far. With the interest of time, we will take a couple of more questions, and then we will ask our President Suresh Reddy to give his brief remarks. So let's just take last two questions, Gunjan.
Okay, so another question came up repeatedly is that whether AC inhibitor, where this virus actually attaches by the AC receptor, and does AC inhibitor is problematic in this situation. Just my 2 cents on it as being a cardiologist. So as my understanding, what happens when you take an AC inhibitor for the hypertension, what happens, body tries to fight that. And as long as, like, if you are blocking certain amount of AC receptor with AC inhibitor, body upregulates and produces a little bit more AC receptors. And that may have be a problem, because if virus can attach to those over exerted AC receptors, then you can have a much severe disease. But at this point, AHA and ACC does not recommend to stop AC inhibition for the patient with COVID-19. But I'd like to get a take on by Anil. Do you have any other comment on the AC receptors?
Yeah, I think, and there was someone mentioned that there may have been, like, we're not sure if how involved ACE is and all this. And I think they've looked at histopathological studies on patients in Italy and other countries, and they found that these viruses are attached to these receptors on immunohistochemistry, staining, and whatnot, and not just like a few. We're talking millions are embedded within the vasculature, and we found like the ability for these spikes on the viruses to basically attach to the receptors themselves. So there is a lot of convincing evidence for this, but I agree. I don't think there's any indication to stop the ACE inhibitor right now. And there's just so much information coming across the table right now. Some people are actually suggesting it may actually work as a therapy. To start ACE inhibitors in some patients. So it's all over the place.
Yeah,
You're getting conflicting information.
I think there's what we call observation of somebody instead of evidence-based. So whoever finds something, he would say that useful versus finding the evidence-based practice that we always believe in.
All right, and I guess, do you have one more question?
Yeah, we'll take the last question, if any. Otherwise, I'll ask Dr. Reddy to do the closing remarks.
Okay, so last question is for Anil again, that people are really, really interested in outpatient anticoagulation. So there is a few choices. As a final nail on the coffin, if you want to put that question to the rest, that either aspirin 81 milligram is okay. If the D-dimer is high, it is reasonable to start a systemic anticoagulation, or it would be aspirin plus Plavix. Anil.
Wow. I mean, I don't even know how to, I think right now for the D-dimer aspect of it, the antiplatelets is not the way that I'm seeing that people are consensus practices. It's more about the heparinizing the patient as is the approach on that one. If you're suspecting that the patient has like some kind of unstable underlying athero, I think antiplatelets would probably be better. If the patient has no other symptoms and they've kind of went their course of COVID infection as an outpatient, just dual antiplatelets if it's and this is from basically validate that from a number of different trials recently that came out showing that if, depending on the size of the stroke or the small, if there's a TIA or stroke, if the patient is completely asymptomatic from a stroke standpoint, didn't have a stroke, but you're just worried for primary prevention, given post-COVID, but underlying risk factors, then I think just a baby aspirin would be enough. So it actually is a case-by-case basis, looking at the burden of disease before you make a decision like that.
Back to you, Subbu.
Yeah, thank you so much. I want to thank all the speakers for wonderful presentation and excellent information, very useful for everybody in daily practice. I want to also thank Gunjan and Asles for being a volunteer for the panelist. At this time, I want to ask our President of AAPI, Dr. Suresh Reddy, to do the final closing remarks. Dr. Reddy, are you here?
Yeah, thank you. Can you all hear me?
Yes.
Okay. Thank you, Sumul, for putting your heart and soul into this and getting this together in a record time. Thank you, speakers, Bharat Narvetla and Anil Yallapragada and Nikesh Ardeshna, and the moderators Gunjan Shukla and Ashlesh Dani, and special thanks to Gaurav, Vivek, and Brahma, who kept the audience busy in the sideways in the chat room. Thank you all, and we will do one more neuro session when maybe next month, when we have more information in neurology, because it looks like the neuro symptoms are coming late, like late manifestations rather than earlier manifestations. So we'll be getting more and more information. And as you know, I am also an interventional neuroradiologist and endovascular neurosurgeon. So my heart especially goes to the brain. Thank you so much. Thank you all for joining. Stay tuned for other sessions coming up. Thank you.
I want to just end with thanking Vijaya for putting all these things together. Thank you, Vijaya.
Suman, you want to ask anyone, all the speakers, to closing statements? 10 seconds.
Sure. All the speakers, you have 10 seconds to have a closing statement if you choose to.
Anil?
Oh, I've just put my email address. I know a lot of people have been texting me for my email address. I just put it in the chat box. It's YALLAP as in Peter, AV@gmail.com. Thanks again for everyone.
Thank you.
Well, to be honest, this is a very different beast. We don't understand a lot about it. And it acted on multiple fronts, and still need to study. One thing for sure, it has changed my perspective of life and the way I approach patients. And it has changed our way of medicine, the way we practice. So I think the worst is not over. I mean, the worst may be over, but the COVID is not over yet. I advise all and request you all to, be safe and be good.
Nikesh?
Nikesh has to leave.
Okay. Go ahead, someone. You're the last one. Fine.
Yeah, so I really want to thank everybody. I think as everyone said, we are not done and over with this situation yet. Please stay safe. Please practice social distancing and use your mask and everything else that we do as a proper measures to avoid contacts with the disease. And good luck, everyone.
Thank you. Good night.
Good
Thank
night.
you, guys. Bye.
Good night.
Good night.